to the lung volumes and capacities, dynamic. What do you understand by dynamic? Dynamic means whenever we take the time factor into account, then it is called as dynamic. So a first thing that I have to do is I should create an x-axis where there is time. Then the volumes will be recorded similar in the y-axis. So instruction given in this, the person will be breathing in and I'll ask him to take a deep inspiration. Followed by that, I'll ask him to stop, then expire as forcefully as possible. Last time I was asking to do it maximally only, but here it should be fast and forceful. Why fast and forceful? Because I am going to take the time factor into account. So there will be a curve where the expiration part will be like this, and we have increased the speed of the tracing. Why we have to increase the speed of the tracing? To spread out the wave, I have just increased the speed of the tracing. Because I want to calculate it for the first second, second second, and third second. So whenever I increase the speed of the tracing, it is going to give me a longer wave so that I can split and identify what event has happened in particular second. So what is this entire value? This is the vital capacity because it is including all the inspiratory reserve volume, tidal volume and expiratory reserve volume. But it is called as forced vital capacity. Why it is called as forced vital capacity? Because I am taking the time factor into account. Then after that, I will plot 2 points wherein the what amount of volume is thrown in the first second and what amount of volume is thrown in the second second. That is called as FEV1 and FEV2. This FEV1 is forced expiratory volume at the first second, then FEV2 is forced expiratory volume at the second second. Why this FEV1 is very, very important? We will try to understand when we study about the diseases. So what is their normal values? The FEV1 normal value is 80% of FVC. What does it mean? Whenever I ask the subject to do a forceful expiration, in the first second itself, he will be throwing out 80% of his vital capacity. He is throwing out so much of air in the first second itself because our airway is so open and it is able to throw out a lot of air. Then 90 to 95% is thrown out in the second second. Then 99 to 100% will be done in the third second. So in a normal individual, he will be able to do a complete expiration in 3 seconds itself. So there is a ratio which is called as FEV1 by FVC. This ratio is between the FEV1 to that of FVC. And I told you the normal value is 80%, which is 0.8. This is one of the most important ratio because it will help us to nicely differentiate between a restrictive lung disease and an obstructive lung disease. First of all, why we have to differentiate between obstructive and a restrictive? Because the treatment and the approach are completely different for an obstructive disease and for a restrictive disease. And this dynamic capacities are helpful in identifying the restrictive and obstructive disease. That is why all the clinical questions are now based on this dynamic graphs, not the static ones. Now let's study about, I'll tell you initially what is about the restrictive disease and what is about the obstructive disease. Then we'll discuss what happens to the all the volumes and capacities which we studied previously. So coming to the obstructive disease. So suppose this is a normal lung and this is an obstructive disease lung and this is a restrictive disease lung. So observe and tell me what I have done it in the obstructive disease. In the obstructive disease, the parenchyma is completely normal. I have just shaded a black region in the airway. So obstructive disease means there is huge problem in the airways of the lung and especially the smaller airways of the lung. They are severely affected. So now tell me, inspiration will be affected or expiration will be affected? Of course, both will be affected, but at least during inspiration, there is an opening up of the alveoli. So it will open up further and air can move in. But during expiration, this obstruction will further make the condition very worse. So this will be a severely an expiratory problem. This is going to be a severely an expiratory problem. Whereas coming to the restrictive disease, I'll just ask you to remember only one simple thing. Just remember it is a small lung. Don't think that the lung has become small. The parenchymal portion of the lung, for example, this is the lung. The parenchymal portion of the lung is not used now. It is not useful now. So what has happened? The lung has become small. Don't think the lung is there, but its functionality of the lung has become small. The parenchymal factor or any skeletal disorder where the lung is not able to move efficiently. That is also a form of restrictive disease. So let's see the examples of obstructive and restrictive disease. So coming to the examples of obstructive disease, the COPD, chronic obstructive pulmonary disease, which includes the emphysema and bronchitis. Then asthma, bronchiectasis, cystic fibrosis. All this will come under the examples of obstructive disease. Then coming to the restrictive disease, the interstitial lung disease, then fibrosis of the lung, then skeletal disease. Even in skeletal disease, the lung can be normal, but its expansion is not happening. So the lung is full capacity is not used and it is behaving like a restrictive pattern. So now with this knowledge, let's try to understand what happens to all the volumes and capacities in these diseases. So coming to the obstructive and restrictive diseases and their values. This TLC, that is the total lung capacity, in an obstructive disease, it can be normal. It's pretty simple because there is problem with the airways. Parenchyma is normal, so the TLC can be normal. Sometimes it can be increased also. Pay attention here because this increased one happens only in one disease, that is emphysema. So a few more details about emphysema. What happens in emphysema is the elastic tissue of the lung is damaged. So what will happen is the compliance or the expansion of the lung is increased. So what will happen? More air will enter. The lung alveoli is not able to collapse back. So what will happen? This air will stay inside itself. This form of disease is called as emphysema, and what happens here is nothing but the air trapping. So whenever air trapping happens, what is going to happen for the total lung capacity? It is obviously going to increase more than normal. So just remember emphysema. Whenever you see anywhere total lung capacity is increased or the compliance of the lung is increased in a disease, it is nothing but an emphysema. You can close your eyes and tick the answers. Then restricted disease, I told you the parenchyma is affected. So obviously the total lung capacity will be decreased only. Then what happens to the forced vital capacity? Forced vital capacities is decreased in both of them. One disease we are having a airway problem. So when I try to do it forcefully, it is going to obstruct. Obviously it will be decreased. Another restrictive pattern, what is happening is already the lung itself is small. Then how come the FVC will be increased? It also will be decreased only. Then coming to the FVV1, this makes a huge difference. It is very, very important. In case of an obstructive disease, FVV1 is percentage of the FVC. Whenever there is obstruction, I am asking the subject to do it forcefully. In obstructive disease, what is the problem? The airway is the problem. Whenever I ask the subject to do it forcefully, what will happen? There will be sudden closure of all these smaller alveoli. So whenever we do it forcefully, the FVV1 is going to decrease a lot. That's why I have put so many decreased arrows, which is it is decreased so much. In restrictive disease, it will be decreased, but still it is not decreased as severely as in case of an obstructive disease, because in restrictive disease, the airway is completely normal. So coming to the ratio FVV1 by FVC, now tell me, if the numerator is decreased a lot, what is going to happen? Obviously, the ratio is going to be decreased. So these two will give me an idea whether it is an obstructive disease. The FVV1 is decreased so much and the FVV1 by FVC is also decreased. Whereas in case of a restrictive disease, this FVC and FVV1 both are decreased in proportion to each other. Whenever they are decreased in proportion to each other, the ratio will be normal. Sometimes the ratio can be increased also. So this table is very, very important for all the MCQs to be attended. So this can be given in a graphical format also. Now let's try to understand. So this normal one, this is the normal one. Now look at the graph on the left side. On the left side, this is the FVC. FVC is decreased. FVC decrease can be seen in both obstructive and restrictive. But see the FVV1. It is very, very small. There is very, very small amount of FVV1. So what is this disease? This disease is nothing but the obstructive disease. Now coming to the graph on the right side. What is happening here? Here the FVC is decreased in comparison to the normal. But see the FV1. Out of this FVC, still more amount of air is going to be expelled out. So this is nothing but our restrictive disease. So even these graphs can be given and asked, which is an obstructive disease and a restrictive disease. And we should remember the examples also, because in 4 choices, we will be giving the examples in the options. So now coming to the another version of this graph, which is in complete trend now, even for AIMS as well as other entrance, this flow volume loop of respiratory tract. It is pretty simple. It is just the same thing that we studied. It is given in a different manner. This flow volume loops are recorded by the computer. The subject will be doing the same spirometry like inspiration and expiration, and the recordings will be recorded by the computer. So as you can see here, this is the residual volume, RV we have written. Then this part is the inspiration. So this part is inspiration. At the end of inspiration, what is the amount of air present in the lung? It is nothing but the total lung capacity. Then we will ask the subject to expire out as forcefully as possible. Then the curve will come back again to the residual volume state. So this portion is nothing but the expiratory part. The above portion is the expiration, the below portion is the inspiration. This topmost point is called as the peak expiratory flow rate. This is the highest point, highest peak that can be achieved during expiration. Peak expiratory flow rate. Now, just imagine and tell me what is going to happen in a restrictive disease and an obstructive disease. That is the question. So, a restrictive disease, I gave you one clue, which means that the lung is small. So, what happens to this diagram? Just look for yourself. This diagram is going to be smaller. That is the inside one is the diseased one. Here, all the dimensions, when you see the dimensions, their dimensions are exactly same, just their volumes are reduced. So this is our restrictive disease. But what happens in case of an obstructive disease? Obstructive disease, I told you, usually the problem is not with the inspiration. So the inspiratory curve can be completely normal. As you can see here, the inspiratory curve can be completely normal. But what is happening during expiration? Expiration, initial part comes from the larger alveoli. Of course, the trachea and bronchi are the larger bronchi. But the later part comes from the smaller airways. And obstructive disease, smaller airways are the one which is damaged. So there will be a scalloped appearance in the obstructive curve. So there will be a scalloped appearance in the obstructive curve. So this is the clue to it. So these are the diagrams which can be given and asked in the MCQs.